So let's invite first Dr. Rini. She's going to be speaking on May-Turner syndrome when the vein becomes too fragile. Dr. Rini has been had worked in Indraprastha Apollo Hospital. She was one of our fellows. She has done phenomenal work in Indonesia to develop interventional cardiology and also vascular interventions in Indonesia. So over to you, Dr. Rini.
Okay, good evening, everyone. First, thank you for Prof. Khanna for inviting me to join the great meetings. And I missed the Delhi or Apollo Hospital also the meeting, of course, because for the last 2 years only online we can meet at the meeting. Today I have present my case about May-Turner syndrome when the vein becomes too fragile, a case report. I have no conflict of interest in this case presentations. As introductions, that incidence of first is symptomatic DVT in the adult is about 50 until 100 per 10,000 population per years. And May-Turner syndrome is, or MTS is referred to chronic compression of the left iliac vein, again the lumbar spine by the overlying right common iliac artery. MTS is anatomical risk factor for lower extremity vein thrombosis, especially left lower limb. This is case report about Mrs. LMN, 63 years old, a Chinese lady. From the anamnesis, the patient have a chief complaint of recurrent leg swelling, dominantly in the left leg, more than 1 year. And she already gone to many doctors, but not improved. And 2 weeks back, went to the cardiologist and received rivaroxaban and diosmin, but also there is no improvement. In this patient, no history of trauma, malignancy, or prior clotting problem herself or on her family. For physical examination, blood pressure otherwise is normal, with only swelling dominantly on the left leg with hyperpigmentation in these patients. From laboratory finding, we found that the dimer is about 12,000 and fibrinogen, hemoglobin is normal, chest X-ray normal, echocardiography only find that diastolic dysfunction as the woman is already 60 years old. From US ultrasound Doppler, we found that the patient have left femoropopliteal DVT with normal arterial flow, and CT venography is iliofemoropoppliteal DVT in the left legs. So the patient have working diagnosed with iliofemoropoppliteal or proximal DVT of the lower limbs. At the times, I gave the patients with enoxaparin, diosmin, atorvastatin, elastic compression for Barnard stocking with leg elevation. At the time, I still thinking about the conservative therapy. But after 1 week, there is no improvement. So I planning the patient to undergo a catheter direct thrombolytic therapy. So patient on the prone position, I put at 5 French seat and also GR, chest skin right for 5, and I underwent the venography. There is total occlusion from femoral vein, and I advanced the catheter and also thrombus along the iliac artery. So the patient get alteplase bolus for 10 milligram followed by continuous infusions and unfractionated heparin 200 units through the sheet. And patient transferred to ICU for close monitoring. The following day, I saw that the left iliac vein is compressed with the spur. So this patient is with May-Turner syndrome. And then I am pre-dilated. I plan to put the stent. So I pre-dilate with the balloon 60 million balloon gradually for up to 10 ATM. But from venography evaluation revealed a perforation on the left common iliac vein. So I put the distal left common iliac. I know that there's a perforation, so I put the 5 French catheter to the right, iliac vein to know the length between the bifurcations and the healthy, and I evaluate where is the location of the perforation. And then I put, instead of self-expandable stent as I planned, I put the covered stent 1240 millimeter to maintain the patency of the live common iliac vein and to close the perforation due to complication of the procedure. Here I put the covered stent, and this is the final result. As we discussed a bit about MTS's definition, isolated live lower extremity swelling secondary to live iliac vein compressions, first described by Mike Morris and defined anatomically by Meyer and Turner in 1975. And the left iliac vein is usually located posterior to the right iliac artery and can be compressed between the artery and the 5 lumbar vertebrae. Most the patient present with left lower extremity DVT, like in my patients with symptom with left lower extremity swelling, pain, venous claudication, ulcerations. And the clinical stage of MTS is the first stage is asymptomatic with left in compression, and the second stage formation of the venous pore, and the third is left lower extremity DVT, like in my patient. Modality for the MTS is CDTT with or without stent placement, balloon angioplasty, pharmacomechanical catheter direct thrombolysis with stent placement, and anticoagulations. Venous stenting indication for the chronic obstruction, like in this patient with contraindication, is uncorrectable coagulopathy and local or systemic infection. As the complications is early thrombosis, less than 30 days is about 1.5 until %, late thrombosis is 5%, extension stent into APVIC is about 1%. Rare complications is venous-stellar or perforation, like in this patient, is or injury adjacent arteries and fracture and stent dislocations. As a take-home message, when encountering unexplained proximal DVT, Turner syndrome should be considered, and those diagnosis and treatment must be performed to prevent the recurrence of thrombosis. The optimal treatment of MTS include CDTT to relieve the symptom and followed by stenting placement to relieve the stenosis. Perforation as a complication could happen and should be treated properly during endovascular treatment in MTS. Thank you.
Thank you, Dr. Rini. That was wonderful. So we'll have the discussion in the end. And let's move on to the next presenter.